This is the Ross Information Processing Assessment Test, second edition, by Deborah Ross Swain. The standardization for this test was done from September to October in 1994 with 126 subjects diagnosed with TBI. Ages 15 to 77, the average age was 31. Subjects lived throughout 9 states, their first language was English, and they had a level 5 or above as defined by Rancho Los Amigos scale of cognitive level and expected behavior, which is confused, inappropriate, and non-agitated behavior, but responds to simple commands fairly consistently. There are 3 validities with this test. The first validity is construct validity, a 3-step procedure. First, several constructs presumed to account for test performance are identified. Second, a hypothesis is generated based on the identified constructs. Third, hypothesis verified by logical or empirical methods. The methods are: RIPA values should intercorrelate, test scores would correlate well with similar measures, factor analysis should support the constructs that underlie RIPA2, and items of each subtest should relate highly to the total score of their subtests. Second is content validity. There are 3 demonstrations. First, rationale for subtest format and selection is presented. Second, panel of 3 professionals known to have practical and theoretical expertise in the field of TBI were asked to assess RIPA2. Third, validity of items is demonstrated statistically by the results of item analysis procedures that were used to validate items during the revision of the test. The third validity is criterion-related validity. Results of comparisons of RIPA2 subtests to selected subtests are presented. Selected because they measure the same skill area, which is cognitive processing. RIPA2 scores are valid with regard to criterion-related validity. Coefficients are significant and of considerable magnitude. The reliability for this test is inner scorer reliability. 3 clinicians independently scored a videotape recording of the administration of the original RIPA. Overall level of inner score reliability is 99.5%, which is an excellent level of inner score reliability. We got this by calculating the median raw score for each subtest, found the differences between median raw scores and other 2 scores for the subtest, and we summed the differences. Then we divided the differences by the total raw score points to get our percentage. This test is used with patients diagnosed with traumatic brain injury from ages 15 to 77. Its use is to assess the current state of the client, quantify the amount of cognitive linguistic deficits, and determine the severity level for each one. It also develops goals and objectives for future rehab. There are 10 subtests. 10 questions per subtest. Subtest 9 is timed. The questions asked according to areas being assessed. Expert clinicians can complete the whole assessment in 45 minutes. Depending on the patient's fatigue level, you can do the test in 1 or 2 sessions. The subtests are as follows. Subtest 1, immediate memory. Subject repeats numbers, words, and sentences of increasing length and complexity. Subtest 2, recent memory. Subject recalls specific newly acquired information relative to his or her environment and daily living. Subtest 3, temporal orientation, recent memory. Subject is asked 10 questions relative to time. Subtest 4, temporal orientation, remote memory. Subject answers questions related to time concepts involving his or her remote memory. Subtest 5, spatial orientation. Subject answers questions related to spatial orientation, categorization, and sequencing. Subtest 6, orientation to environment. Subject answers questions relating to his or her awareness and perception of their environment. Subtest 7, recall of general information. Subject recalls general information in remote memory. Subtest 8, problem solving and abstract reasoning. Subject responds to 10 problem solving and strategy reasoning questions. Subtest 9, organization. Subject recalls category members within a 1-minute time limit and category type given by 3 category members. Subtest 10. Auditory processing and retention. Subject answers yes/no questions containing temporal, spatial, and comparative stimuli. The test is scored with raw scores and diacritics. Raw scores are the total scored correct, and they are converted into percentiles and standard scores. Standard scores provide the clearest indication of individuals' RIPA2 subtest performance. It's converted from raw scores using the appendix based on statistical properties, and they can be compared. The standard score mean is 10, and the standard deviation is 3. The percentile score are values that indicate percentages of distribution equal to or below a particular score using the appendix. In order to prepare to give this test, an examiner needs to read and become familiar with the test questions, manual, and instructions. The test is easy to administer, as long as the examiner can follow the directions and keep on task and not scare off the patient. It's also good for the examiner to mentally prepare for a patient at any cognitive level. You never know what answers you will get, and it's always good to be prepared for anything. The limitations and cautions seen with this test are as follows. This test only comes in the English language. There is no visual field assessed in this test. A patient's fatigue level can become a limitation when they are too tired to carry out the test. Examiners' poor skills of interacting and following directions can definitely be a limitation on this test. The last limitation is that there is no subtest assessing attention. This concludes the presentation on the Ross Information Processing Assessment, 2nd edition. Thank you.